We can hear you, sir. You're muted.
Yeah, I'm unmuted now.
Okay. All right.
Good afternoon,
Okay.
everyone.
Good afternoon. So as not to interrupt, I'll just turn off my video and audio. It doesn't interrupt your you, sir. Thank you so much. Thank you again for joining us. I briefly introduced you to everyone, but I guess you were not online then. But
No
then I'll just
problem.
leave it to you so you can introduce yourself and then start the session. Thank you again for agreeing to for teaching us today. Thank you. Okay, I'm going off now.
Okay. Um, Good afternoon, everyone. My name is Olayinka Shayomi. I'm the senior registrar with pediatric surgery. Can you hear me?
Yes, we can hear you, sir. We can. Yes.
So my name is Olayinka Shayomi. I'm the senior registrar with pediatric surgery at UITH Learning, and I've been asked to discuss with you on the principles of pediatric surgery care, and it's something that is very important for those that are interested in any specialty that operates on children, that takes care of the medical need of children. I'm trying to see how to share my slide. Sorry, I've not used this.
It's fine. Please take your time. Have you seen any option for that?
Not yet.
Okay.
Okay, I've seen an option.
Okay.
Sorry about that. I think I'll share the screen instead, since I've already.
Okay, sir.
Hello, can you see the slides? Hello? Is the slide visible and is it transitioning?
Yes, yes, it's visible. But not
Okay,
transitioning. I can only see the first
so
slide. The
the first slide. All right, so
Yes.
just give me a minute.
Okay. So now we can see the slide.
Yes, you won't be able to see it yet. I will.
Okay.
All right. Um. All right. Can you see it now?
Not yet.
No slide.
Up now. Yes, yes. I can see the outline. Yes, it's transitioning now. We can see it.
Okay, good. So I'll be talking about principle of pediatric surgery care, and these are just the outline I will be speaking on. In pediatric surgery, we tend to take care of the surgical needs of children, although there are many other surgical specialties that do operate on children. They are more specialized and they give some specific care. But pediatric surgery tends to give general care for those requiring certain specific surgeries. And one of the things that is peculiar about pediatric surgery is the fact that children consist of a wide array of patients, including someone as small as a preterm neonate and to children that are almost adults, as old as 17. And these have varying physiology and anatomy, and therefore no particular thing fits any one of them. For instance, among infants are transitioning. Basically, when you talk about a neonates are still transitioning from intrauterine life, which was largely dependent, and then by the time they become infants, they are transitioning into an extrauterine life. So there are so many things that differ in terms of physiology. They are transitioning in terms of their circulatory system and in terms of how they adjust to various stress, such as surgical diseases will impact on them. So there is no particular formula that fits them all. It's one of the things that one needs to take into cognizance. Then again, you have a wider categories of patients. For instance, in terms of gender, we speak about children being male, female, or even a DSD, which are children whose gender cannot be determined at the time of birth, and they have problem with their development in terms of sexual development. So you cannot classify them into that regular binary classification, the male, female. And even nowadays, that division is getting more blurred out with the transgender and other categories of people. Again, in terms of age, there are some areas of we have infants, toddlers, those that are preschool age, those that are school age, and adolescent. These are all varying divisions. But again, if you look at infants, for instance, among infants, there are those that are still 0 to 28 days, which are neonates. Neonate means newborn, but some people have gone further to say not necessarily, that newborn may actually be within the first 72 hours, and then subsequent you can refer to all of them as you can refer to them as other neonates. But what is acceptable worldwide is that neonates and newborn are actually the same, and then other infants, because neonates are also a subset of infants. The other infants are those that are 1 month to 11 months of age, and so on and so forth. And one of the things that is quite intriguing about them is that all these, they undergo changes according to how grown they are. The further they are from fetal life, these two here are fetuses, but here you have a newborn. But the older they are in terms of age, certain changes occur in terms of the head, the size of the head relative to the body. They have a very large relative to the remaining part of their body, and the abdomen as well. The abdomen tend to be rectangular, lying on the long side, whereas for those that are beyond school age, beyond the preschool age, they have a rectangular abdomen which is sitting on the short side of the abdomen, just like what would obtain in adults. So these are some of the changes that you find in them. Uh, let's just take a brief history. The first pediatric surgery interest as a specialty is that in Paris, where there is establishment of the hospital for sick children in Paris. That's 1802, and by 1852, something similar was in UK. That is the Great Ormond Street Hospital for Sick Children. And at the beginning, there was a tendency for it to be only children with medical needs that are taken care of at this hospital. However, Charles Dickens, the famous author, is one of those known to have supported the care of any children, all children, rather than only those with medical illnesses being taken care of in such hospital. And some people have published the scope of surgery in the Great Ormond Hospital for sick children in the British Medical Journal. That's one after, and then T. Holmes also did something similar in 1868. The first established pediatric surgery practice that was exclusive for pediatric surgery was in 1919 by Herbert Cole. However, the first training program was established by William Ladd, an American surgeon, in the Children's Hospital at Boston. He was the first surgeon in chief at that Children's Hospital. He was a general surgeon before he dedicated his practice to pediatric surgery. Likewise, Robert Gross, who was his first trainee, who had a background in pathology, worked on patent ductus arteriosus ligation based on his observation of infective endocarditis specimen that had been taken, and this formed the basis for him proposing how and the importance of ligating the patent ductus arteriosus. He also published the first Ladd's work, that is the abdominal surgery of infants and children, in 1941. Over Swenson, we all know, described the pathology of Hirschsprung's disease and also preferred a solution in the operation that is named after him. And it was a Canadian surgeon, Bidmore, who petitioned the American Board of Surgery so that pediatric surgeons can all receive special options in pediatric surgery. So it served as the basis for education of pediatric surgeons in America. Pediatric surgery has many branches, but the parts that we'll be looking at are for those that are specialized in pediatric surgical care. That is neonatal surgery, general pediatric surgery, pediatric urology and gynecology, pediatric colorectal surgery, hepatobiliary surgery, oncology, and of course, fetal surgery, which is still an emerging aspect of pediatric surgery. All these is not by any means exhaustive, because there is also pediatric neurosurgery, but a lot of times neurosurgeons do take part in the care of children, but they are not specialist pediatric surgeons. And in some places, pediatric surgeons have been known to do some pediatric neurosurgery. Similarly, orthopedics, which is even a tougher specialization to master, there is also pediatric orthopedics, which is still in our own setting here in Nigeria. It's still a developing aspect of pediatric surgery. So what are the principles we'll be looking at? The first thing is on the issue of diagnosis, management, follow up, and then on the transition of care so that children forever. So in making diagnosis like in other aspects of surgery is based on the tripod of history taking, physical examination, investigation. It's all these that will make up the diagnosis of a child. However, in addition, in pediatric surgery, we also take the integration of other problems that are common to children serious. The meaning is that we check the child in a holistic manner so that there is no aspect of the child that is missed, and we follow through to ask about nutrition. We check their immunization and how they are growing and developing. We also want to look at antenatal, perinatal, and postpartum period to look at those things that can be a risk for their health. And generally speaking, as children grow older, we tend to downplay on those other aspects. For instance, in a 12-year-old with, say, acute appendicitis, much emphasis will not be on the antenatal history, perinatal, and postpartum. But for a neonate and infant, and indeed even a lot of us, things that we need to look at will date back into their perinatal event. So, in other words, what we do is a comprehensive assessment so that we'll make a complete diagnosis that will ensure holistic management. So, the pediatric surgeon not only takes routine history as a, pardon the use of that word, a mindless fact collector who will take a routine history and make examination, and then will not correlate it with anything, but just miss some important clues in the process and make a diagnosis which faulty. However, what we need to do is to marry the presenting complaint with the basic principles that we have from the physiology of children as well as embryology, because they are closer to the embryonic period. And a lot of time, pediatric surgery has to do with embryology. So we take history on that basis. Once we have that, we also use the basic principles of pathology. And then this gives us an idea of the likely diagnosis. Once we have that, then this will help us, guide us into a focused, goal-oriented history and physical examination, which will make us arrive at the appropriate diagnosis. This is what will make us a logical strategist in making a diagnosis for a child who is presenting to us. Now, in taking history, we generally in pediatric surgery will rely on information that is given to us by caregivers most of the time. In addition, some children, maybe starting from those that are up to 6, 7 years of age or even above, and as they get closer to adulthood, it becomes easy. But a child at an appropriate age will have varying degree of contribution to the history that we can obtain. In addition to the regular history that we take in adults, there will be need to include the history of the pregnancy, the peripartum events, as well as the postnatal history. We also to take of the nutrition development, the immunization history, as well. And then we'll also want to relate the symptoms that these children relate, such as a child that has vomiting, a neonate developing vomiting about the time of birth. Such as something that is congenital as the cause of his vomiting. Whereas in an infant that is presenting with bilous vomiting, an infant between 3 years or even a toddler for that matter, we will be thinking of something else, especially if there has not been an antecedent before. We'll be thinking of something like intussusception. So these symptoms are usually timed with the milestones the patient has attained. So in this one, when we take history, the first thing we have to do is to gain appropriate rapport with the child. Once we have introduced ourselves well, we gain rapport with the child. And one thing about care of children is that you need children to really be friends with you before you be able to attain their trust. And then you also get history, at least the presenting complaint, as well as the visual clues. From those, you make a tentative diagnosis, which will give you an idea of what other histories to elicit from the patient. And then you can now do your goal-oriented direct questions, which will further help with your history, and then the diagnosis will be solidified and you have an idea of what you will be looking for when you are going to examine. And by the time you are examining, your examination will also be goal-oriented and directed. And then you'll be able to make diagnosis. You may have some unexpected findings, and then you make a new tentative diagnosis before you go on in that cycle. By the time you have made a goal-oriented examination, you'll also be able to make appropriate inference that will direct the direction of investigation, laboratory investigation, to refute differential diagnosis and to confirm the actual diagnosis. And once you have confirmed diagnosis, you'll be able to make correct treatment. So, physical examination, one of the things we have to bear in mind is that we have to be flexible. It's not necessarily that what you will do as a doctor is to examine in the order that in the predetermined order as it is in, say, Hutchinson's or Hamilton Bailey. No, it doesn't work that way with children. We have to be flexible to what the child will allow at that time. And then the physical examination has to be designed to be convenient for the child. We tend to defer those things that will be painful for the child to later on when the child have been comfortable with us. And then we tailor the examination to the child. It's not that you want to examine every aspect at one go, but you want to do the essentials for the child so that the child will cooperate, and then you'll be able to make appropriate inference. And again, a lot of times the caregiver, usually the mother, should be around and within the child's field of vision. In fact, better still, the child could be seated on the mother's laps. That way, the child is in a comfort zone, and then you examine, and usually with warmed hands and instruments, so that your hands do not become uncomfortable or your stethoscope do not become uncomfortable for the child. So investigation is not it's not a time for us to now do routine investigations for children. Rather, what we do in terms of investigation is as required, and for children, it's not right for us to be using the same specimen collection or even laboratory methods for their blood tests. For instance, you have a child, you want to do a full blood count or complete blood count, electrolytes, urea, and creatinine. You want to do such tests for. The vacutainer bottle that collects specimen for adults generally will require uh, about 5 mils for blood to be adequate, or at the very least 3 mils. Otherwise, the sample will be too little for the anticoagulant that has been prepared in the respective bottles. Rather, there are special bottles for children such that you'll be able to collect adequate sample, which is not too much for the child, because the child's blood volume is for a neonate 80 mils per, for a term neonate 80 mils per kilogram body weight, and as the child grows on and on, it becomes 70 mils per kilogram body weight, like that of an adult by the time they become almost adults. So we need to use micro methods rather than the one that we use macro methods for, such that if there are point of care testing device such as iStat, it's better to use such rather than using those techniques of blood testing that would require larger volumes. Then again, for imaging, imaging should be done as fast as possible, and they should minimize radiation exposure to the child, and the child should have familiar face nearby to obtain their cooperation. However, you would all agree with me that there is no single imaging modality which fills all these criteria. For instance, the computed tomographic scan is quite fast, but it has a lot of ionizing radiation exposure, and it has about 1 in 1,000 lifetime risk for inducing cancer. Whereas magnetic resonance imaging takes a longer time to obtain with no radiation. However, it requires that a child remain still during this period, which is almost an impossible requirement. So, as a result, children going for MRI would require sedation or even anesthesia to some extent. Radioisotopes can use minimal dose of radioisotopes, and they are rapidly eliminated by the kidney or eliminated via feces. In addition, they also have a short time to the time when they actually decay within the body. So, by and large, what we have to do in getting investigation for children is that we have to consider the risk against the benefit of the use of more advanced imaging techniques. But other things where you need and where it will be possible, you use simpler modalities, provided they will give you the appropriate diagnosis. Those are just some key guidelines. So we'll just quickly take a look at some issues, especially with respect to radiologic investigations. That is radiation carcinogenic risk. One of the problems with children is the fact that they are just beginning their life. So technically speaking, you will consider the carcinogenic risk of a CT scan more for a 5-month-old child than you would for a 50-year-old man, because the 50-year-old man in a place where the life expectancy is, say, 65, the man has like 15 years, and there is a long latency period, carcinogenesis. Therefore, you tend to want to order a CT scan with caution with children. In addition, children have organs that, or their cells, most of their cells are dividing at this age. In fact, a lot of organs are still developing. So because they have a large percentage of cells that are still dividing, one would want to be careful in exposing them to carcino or radiation. Another thing is that their immature organs are more radiosensitive. So these all will make us look at exposing them to the risk of carcinogenesis. We'll think about it twice before we go ahead and expose them to a CT scan. However, if there is no choice, one may have to go ahead and do a CT scan. In addition, there is also the risk or the requirement for sedation and general anesthesia. And this is required in examination that requires still patients. Again, there are some patients that are generally non-cooperative. Children may be uncooperative, especially as they are in a strange environment. They are not used to the environment. I'm sure a radiology suit can be quite intimidating, even for the adult, not to talk of an infant or even a toddler, who will even be more disruptive in such an environment. Again, some procedures are quite uncomfortable. You can imagine a child needing an enema in the process. So these are all things that indicate sedation. You may have to sedate a child while giving them some of these agents, so that your test will be more holistic. So you may need to sedate them. Again, one of the things to consider is that for neonates who are prone to apnea after sedation, they are prone to developing apnea both during and then after sedation. They can now they can become apneic. So part of the things that a radiologist that will require is that we have adequate monitoring equipment. They will have capacity to bag mask such patients, and they should also have capacity to intubate. And then they should have a trained nurse within the suite and admitting privileges in less than 5-minute distance from where the radiology suite is, so that if a child requires continuous ventilation, they will be able to admit as appropriate in the appropriate hospital. Another thing to consider includes the contrast studies, and for children that requires contrast, especially something like barium meal that would require oral contrast. The general trend is, rather than using barium, one would prefer to use water-soluble contrast, which, if aspirated, cause minimal damage compared to barium, what barium will cause. The preference is that you will use water-soluble oral contrast. Again, some children will fail to take this, and therefore you can use a fine bore feeding tube, pass it either through the orogastric or the nasogastric routes, and then instill as much as required into the stomach directly, and then you can now obtain your images. For IV contrast, children will generally require a very good intravenous access, so that with as little discomfort as possible. And then occasionally, some of them will require an enema for their investigation. These are just some of the radioisotope scans that are required in children, especially in children with renal diamethaptosuccinic acid or DMSA scan, and then mecaptoacetyl triglycerin, that's Mark 3 scan. These are all renal specific, and they are good for renal scanning. That is the DMSA, and the Mark 3 for differential renal function. One can check this may be indicated especially in children with pelvic ureteric junction obstruction or any obstructive lesion within the renal tract. It will tell the relative contribution of the kidneys, each of the kidneys, to the renal function, and then it will also tell where the obstruction is. Another thing is the HIDA scan, which is for liver pathology, especially for children with something like biliary atresia. So what are the principles of the management? That is, principle of treatment. So number one is that attention to details is very important in children more than in adults. And when we are talking about attention to details, we talk about the need to identify problems, even problems that the patient never mentioned. So once we have identified this problem, we need to itemize each of those problems so that we make sure that all these problems are addressed when formulating a treatment plan. And then there are some special needs in different age groups, such as neonates, the fact that they are very prone to hypoglycemia. So they need to be fed one way or the other, either via the intravenous route. They need to be kept warm since they have immature thermogenesis in them, and they need to be infection free. We need to keep them in an environment that is like a bubble that prevents them from getting infected. In addition to this, there are such care that we need to take, such as hand wash between units so that we don't transfer infection from one unit to the other. We need to make sure people that are sick do not get near neonates, as these neonates still have developing immunity. They are still yet to be exposed to a lot of the pathogens, and now exposing them to a large dose of this pathogen suddenly before they've had time to acquire immunoglobulins passively from their mothers, one will need to be careful about that. So wearing face mask is not a bad idea when around neonates. And then we also need to make sure neonates are well perfused. The meaning is that a neonate should ideally be pink. This will tell us that the neonate is well perfused. Then another thing to take care of is the judicious attention to fluid and electrolyte balance. This is and we need to assess their hydration status. Once we have done that adequately and determined if a child is in shock or not, as children have a higher adaptation, but after the adaptation is exhausted, they crash quickly, unlike in adults who have lesser adaptation, but what they have is that they can actually withstand poor fluid balance for a bit longer time. So we need to put good attention to that and look at their hydration status, looking at the buccal mucosa, how well it is, and then even their skin turgor. We need to take close attention to it. And then children that need resuscitation, fluid repletion, and electrolyte repletion, we need to put them back into balance. But more importantly, fluid first, and then after the assessment, we can now pay more attention to electrolyte balance. Now, generally speaking, children require multi-speciality care, especially when talking in terms of neonate. The neonate will require care not just of the pediatric surgeon, but also of the neonatologist, and in some other periods, that of a nutritionist, and then we may need, in some other cases, some other children, the care of an oncologist, depending on the challenges the child has. One other thing to pay attention to is the dosing, drug dosing, which is dependent on the weight of the child. We need to pay close attention to this. We need to weigh the child before resuscitation and after resuscitation, because after resuscitating, you will now get the actual weight of the child by the time the child is well balanced, which can be made based on their urine output. Once you can say, oh, the child is making adequate urine, then weighing the child at that time will be able to tell us how much the child is. Then again, another problem that can arise is that one may be over aggressive in fluid balance, and then you now overload a child with fluid. The weight will also warn us of this on time, especially if there are other symptoms. Now, once you see those other symptoms, symptoms such as rales and crepitations in the chest, one will take quick attention and then go on to resuscitate as appropriate, to reduce to restrict fluid, and then if necessary give diuretics. So the patient will also need to be warmed, especially for infants and toddlers, from neonates to those that are even up to 5. There is benefit from intraoperatively warm, especially to control their immediate environment and to reduce what they have to expend in terms of energy to keep themselves warm. Generally speaking, general anesthesia is required except in children that are older and for procedures that are amenable to regional technique. Now, certain attention has to be paid when talking about general anesthesia. The anesthesia in children is generally different from that in adults. For instance, they have short neck. Their larynx is more anteriorly placed, and therefore hyperextension, as is done when intubating an adult, is actually going to give us a closed airway rather than an open airway. So one need to pay attention to this. In addition, a lot of things in the child is more rate dependent, such as their respiration, the respiratory, to maintain the oxygen saturation is more dependent on rate of respiration, that is, rather than on the tidal volume, that is, the rate at which they breathe is faster because they have smaller tidal volume and lung capacities. And then for their cardiac output is more rate dependent rather than on the stroke volume. It's more dependent on the pulse rate or the heart rate rather than on the stroke volume. But as children grow older, they come to be to more adult level, so that by the time they have grown beyond 5 years of age, the rate of their heart and also of their respiration are tending towards adults, that of adults. And one other important thing is in about the consent for children. When children are older, especially for children that are up to 7, some would say, For some, they will say once they are up to 13 years of age. And then there's also a wide range in between. Uh, Children need to be counseled. They need to be heard, even though they may not be at the end of the day one that will make the decision. But what children need is to hear, to have the opportunity to hear what procedure is going to be done to them. You need to include them in counseling. You need to let them know that this is what they are about to undergo. And if possible, one would need their assent for surgery, especially as they reach an age like 7 to that 13 years of age. Their assent is needed, as depending on which environment you find yourself in. Now, one final thing that I would like to talk about is on the transition of care. Of course, we said for adolescents, they are almost adults. And the adolescent period is a period whereby a child transits from childhood into adulthood. This is gradual. It spans a long time. By WHO standard, it's from about 10 years of age to about 18 years of age before they attain that adult appellation. So at this period, one needs to find time to transit their care from pediatric surgery to adult surgeons. And it is defined as a purposeful, planned movement for adolescents and young adults with chronic physical and medical conditions from a child-centered to an adult-oriented health system. So these are all things that one has to take into cognizance. For instance, a child that was managed for, oh, sorry about the background noise, just give me a second. Yeah, I'm in a room that is close to a large corridor. Sorry about that. So they will be transiting from adolescents to young adults. And for instance, in a patient that has Hirschsprung's disease, Hirschsprung's disease ideally should have a lifelong follow-up. And when you are following up such a child, one needs to bear in mind the fact that for a child with Hirschsprung's disease, they may develop Hirschsprung-associated enterocolitis at any time, especially if there are subtle changes that they didn't notice at the time when this thing starts to develop and they come to accept it as the norm. So for this reason, one needs to continue to manage. For instance, also for patients with malrotation that has had LATS procedure, the relative location of their intestines are different compared to the regular adults. So these are all things that indicate transition of care. And what is done is that usually we overlap care between the pediatric and adult surgeons. For instance, by the time a child is coming into a point where they become an adolescent, by the time they are becoming an adolescent, say up to 16 years, one should be making pointed efforts, especially in a place where the standard for pediatric care ends at 17 years. So one would start at least 2 years before they become adults. One would start by introducing them to adult surgeons. So the first way is to do a detailed case summary highlighting the initial challenge for which the child was managed. Then what was done for the child and the child's current state In addition, one would also identify any residual problems that the child may have. For instance, for someone that had Hirschsprung, that had transanal pull through or whatever kind of pull through for Hirschsprung's disease, such a child would require a summary highlighting what is remaining. For instance, if they still have some fecal accidents that we need to manage by bowel management, we need to highlight these things and then have such a child to be visiting the adult clinic, maybe visit the pediatric clinic this week, and then the following week or the next visit will be to the adult surgeon. And this can be done over a 3-month period, depending on how frequent the visit to the pediatric surgery clinic is. And then one would need to open a door of consultation to the child or to the adolescent or the young adult, depending on who, during the first year until the child is fully adapted to the care. So these are some of the things that are very germane in the care of children. And I will say that one of the things about pediatric surgery that is the fact that it is quite rewarding in that care of resuscitation of children or care of children, they usually to whatever care they've gotten. And following the care, they may adapt to such an extent that it will be as though they never had the challenge to start with. So, in conclusion, while children constitute the basic template from which adults are produced, they are not miniaturized versions of adults. That evaluation requires careful assessment of our findings on the background of strategy, conclusion, and then we'll be able to find the need of that child. Thank you very much for listening. I have here some resources that you may find quite enlightening. Some of them are my sources for this lecture. Thank you very much once again for listening.
Thank you very much, sir. That was quite
I
an
think,
enlightening session. Can you hear me?
yes, I can.
Okay, okay, all right. So again, thank you so much. Thank you for for coming today to teach us this topic. I mean, I know it's a broad topic, but you really, really, really touched on all the important things. I mean, I couldn't stop writing and just trying to catch most of the important things. And thankfully, we would have a catch up content on the website. I mean, that everyone can always access at any time. So at this point, I don't know if anyone has any questions or comments. So you can leave that in the chat box if you have any questions, please. So we can address the questions and then call it a day. So we'll wait to see if anyone has questions and comments. So I mean, mine I think is more of a personal question. So I mean, in your years of doing pediatric surgery, what do you think are I mean, what would you say personally are some of the major things you've had to overcome, basically your major challenge in pediatric surgery training? If you could just explain that to us briefly, sir. And what you would also advise to all parents.
Well, pediatric surgery is one of the most rewarding surgical subspecialties that I can say, actually. However, it's not without its challenges, especially in a third world country like one we live in. I believe you all agree with me that Nigeria is a third world country. We are still battling with many things. For instance, diseases do not know of third world or first world or second world for that matter, if there is any such definition. But part of the challenges that we face here are things that the environment is not friendly to children at all. For instance, I mentioned about blood tests. Laboratories will still not accept samples that are not sufficient by their methods. And with the volume of children that we take care of in all sorts specialties, I believe that micromethods should be made available, readily available to children. So that's for one. Again, there are so many other things. For instance, operating on neonates. And in fact, that's perhaps the most heartbreaking of all. You will spend so much time, but because you cannot give adequate postoperative care to the neonate, a neonate will suffer needlessly from pain because you cannot give opioids, because your patient cannot be placed on elective ventilation over the first 48 hours, 48 to 72 hours after surgery. Because ideally, such patients should have elective ventilation after surgery. So these are some of the major challenges that you have. And again, the fact that children are made to compete with adults for surgical care. The theater space are limited. You still have to operate children in the same suits or using the same staff that you use for adults. This makes pediatric surgery quite frustrating. Ideally, neonates should not be operated at a time when monitoring is sparse. So all these things are things that makes pediatric surgery frustrating in an environment such as ours. These are some of the things that make it frustrating. But by and large, we still have enough gains whereby you get to have children, you can do some stopgap surgeries. For instance, children with esophageal atresia, some have decided to stage the surgery such that they can replace the esophagus outright rather than using the native esophagus. But the child would have benefited once and for all from a primary esophagostomy rather than a stage surgery, which there are very few people in Nigeria that do that. So I think what we need is a situation whereby our policymakers put their money where their mouth is. That is, they make available funds for health of children. It's not a big deal if child health is made to be free. It's not a big deal if there are special hospitals for children, just like we have in Paris and in the UK, the Great Ormond Hospital for Sick Children. These are all things that are doable here, and I believe that with time, maybe when a lot of private individuals starts thinking about collaboration, especially maybe among physicians and surgeons, they can now collaborate and make available as much as possible such facilities that can entertain children. Only children that they can have exclusive care, and then we can try out children with children, not children with adults. Thank you very much. Have I been able to address your
Yes,
question?
sir. Yes, I think that answered my question. Thank you so much, sir. I don't think we have any other questions. Again, it was quite an informative session. Thank you so much. I will also look forward to inviting you in the future. I mean, for more sessions. So thank you so much, sir. I guess we've come to the end of the session today. Thank you, Dr. Shayami. Thank you.
Thank you very much. Thank you for having me, and have a great remainder of the day,
Yes, you
everyone.
too. Thank you. All right, thank you, everyone. We'll be ending the session now. Thank you. The catch-up content will be made available, so we can always come back to just to watch the session again. Thank you, everyone. See you next time.